I want to thank Ochsner Pediatrics for the invitation to do this grand rounds today on the topic of machine learning in congenital heart disease, from information to intelligence. I've made every effort to be free from bias in my presentation of this topic, but in fairness, I'm obligated to make these disclosures. We have long strived for an analytic approach to data interpretation in medicine. Not that long ago, the power of the tools we had to accomplish this was very limited. Back in the day, it took great vision and a wild imagination to speculate that machines would someday be developed that might have sufficient computing capacity to mimic human learning, and that they might learn enough to support us to provide optimum care for our patients. But our tools have changed. There have been spectacular advances in processing power and some very creative data science and programming innovations, which give our current computers the brute computational force necessary to handle extremely large sets of data and perform enormous numbers of operations quickly enough to be useful. Now, the prospect of machine learning in medicine is realistic, and everyone, including pediatricians and pediatric cardiologists, is wondering where this might all be going. We'll be discussing machine learning and artificial intelligence focusing on pediatric heart disease today. But what, if anything, was the matter with good, old-fashioned, non-artificial human intelligence? The approach to evaluate a difficult patient or difficult data or a tough set of images and making a care decision probably varies from one practitioner to the next. But I think most of us probably consider these things. What did we say about this problem during residency? And then remind ourselves this was 20 years ago. And we might say, I remember seeing a case somewhat similar, and wonder if it was similar enough to use for guidance in the current situation. And we try to recall, what did we do that time that worked? And fret about whether it would actually work again. And what about that Journal of Peds article I read? Do they really know what they're talking about? And we end up wishing we could be more confident and imagining that we might be, if only we had more data and sufficient experience to link the data to diagnosis or to outcomes. So maybe it's worth a while to see if artificial intelligence AI offers us more to promote quality clinical judgment. Because achieving excellence in pediatric clinical practice can be difficult at times. Working with insufficient data and limited experience is like driving down an unfamiliar road in the dark with dim headlights. We take on the overwhelming task of achieving the best outcome possible for each patient entrusted to our care. We know we do not always get it right. When our judgment is informed by limited experience and our knowledge is incomplete, logical decisions are made in the dark based on murky recollections and teachings of less than universal relevance. Poor choices are bound to result, and we sense reaching the limits of our own intellectual powers to change any of this. Artificial intelligence, its advocates would have us believe, is an appealing way to turn up our clinical headlights. Let's explore how AI can take vast amounts of data as inputs and produce output in the form of clinically useful conclusions. But first, we need to define some terms. AI, machine learning, deep learning, and algorithms, these four terms are closely related, but do not precisely have the same meaning. AI is any technique that enables computers to mimic human intelligence. Machine learning is a type of AI that accomplishes this with minimal specific programming. Deep learning, in turn, is a subset of machine learning that uses multi-layered neural networks, which can train themselves to perform tasks on vast amounts of data. Algorithms are the building blocks of AI. They are a set of instructions for intelligence mimicry. An algorithm is a sequential computational technique that accepts input features or variables and produces the output needed to solve a problem. More terminology here describes supervised and unsupervised machine learning. These terms establish the kind of data the machine uses for learning, labeled or unlabeled. The machines on the left are supervised. You see them carefully studying the answer book, the clinical data tied to an outcome in each case, which we, their supervisors, have provided them as a framework for organizing their analytic world. The machines on the right do not have the answer book to study. They are making unsupervised observations of how their world of data is organized, independent of the outcomes. Supervised learning takes place when each case that the machine learns from contains both features and a label. For the cardiac imager, for example, the features can be aspects of the image, which we hope the machine can associate with the label, or the outcome assigned by a human supervisor. The machine then uses an algorithm to map the features to the label, to classify cases or show an association. The machine infers a function that links features to the label, and this function is then tested on an independent set of data to validate it. In unsupervised learning, there are no labels, so each line of data contains only features, and the algorithm identifies clusters of similar cases and therefore can discover undescribed patterns in the data. This simplifies our analytic lives greatly through a process of dimension reduction and elimination of redundant features. So with this as the foundation, let's take a look at some kinds of algorithms that have been applied to actual pediatric heart problems. The neural network is a popular algorithm used in machine learning to take us from an image, like this picture of a cat or a dog, to a useful response about that image, the statement, that's a cat or that's a dog. The building block of the neural network is called the unit, which can be thought of as an artificial neuron, depicted as dots on this cartoon. The units are arranged in layers. There is an input layer responsible for receiving the data, and an output layer which provides the response. And the layers in between are called hidden layers, where the data is transformed through numerous connections between the layers. There are several flavors of neural networks defined by how those connections are constructed. The most basic is a feed-forward neural network, where connections are only one way forward and do not feed back into earlier layers. The recurrent neural network is more sophisticated. It can feed the output of a layer back to the previous step. The next is convolutional neural network that takes this feedback process, assigns weights for the influence one unit might have, and uses those weights to perform an operation on the input as it is fed back. Finally, modular network is a collection of neural networks, all working independently on separate pieces of the puzzle, so that very complex tasks can be broken down into bite-sized, manageable pieces. Let's look at an example using a convolutional network to process a relatively simple image of an electrocardiogram, ECG, to solve a problem. The response you want to get is, this is or is not long QT syndrome. These investigators trained on over 10,000 ECGs from one center and then tested on a data set of 2,000 from another center. The areas under the ROC curves for machine identification of long QT syndrome types was around 0.9, which was better than standard techniques and an expert cardiologist. Now, you may be thinking, well, that's a nice application for a simple problem. But what if the input gets really complex? For example, if we want our machine learn to diagnose congenital heart defects based on echocardiographic images. This is very encouraging work in which the input features are fetal echocardiogram images, and the hidden layer is a modular neural network or ensemble of neural networks. Arnaud and Mungrady trained their machine on over 100,000 images from 1,300 fetal echocardiograms and then validated the performance of the algorithm on 4,100 exams. The program performed extremely well, distinguishing normal hearts from abnormal hearts with a 95% sensitivity and 100% negative predictive value, which was comparable to the performance of clinicians. Suppose we want to go further and try to predict who will have a good outcome and who will do poorly. A supervised learning algorithm called support vector machine is popular for that. The objective here is to find a solution like the dashed red line here, based on imaging features that can discriminate cases with a triangle outcome from those with a star outcome. The basic process is that the machine generates an initial function, evaluates it for errors, which you will hear data scientists speak of as loss. It also evaluates for margin, which is the width of separation between the triangles and the stars. There is a trade-off between the loss and the margin, and then the machine will assign weights to the features to minimize loss while maximizing margin, and repeats the process until the function is optimized, but not so much as to overfit the data and produce a model that does not generalize well. This is an example of using a support vector algorithm to go from imaging data to prognosis. The authors label cases of repaired tautology of fellow in children based on the degree of ventricular dysfunction. The data set of 153 cases, but not large by AI standards, and contained imaging features like ventricular ejection fraction, strain, dysynchrony, and the degree of pulmonary valve regurgitation, along with non-imaging clinical data. And the algorithm was able to identify patients at risk for deterioration with reasonably good performance. This type of image wrangling may be impressive. And as you have noted in some of the examples I showed, we have started to combine the image features with clinical data for the purpose of risk stratification. We are on the road to big data medicine, so it's natural to ask the question that always seemed to come from the backseat of the car. Are we there yet? Everyone seems to be talking about big data, but have we already arrived in the big data era for pediatrics and pediatric cardiology? Well, the answer is ambiguous. Yes and no. We are well on our way with managing the images and getting assistance with image segmentation, echocardiographic view recognition, functional assessment, and even recognizing a few congenital defects. But to fully arrive, however, we need to make the big leap from simply handling echo images as big data to combining it with other clinical, biochemical, genetic, and demographic information for outcome prediction suitable to personalized medical care. Ultimately, this would take echocardiography to the world of omics. We are clearly not there yet, but it's time to talk more about big data and the potential to combine data from diverse sources. There are many definitions of big data. Most of them look something like this 2016 statement from DeMoro et al., who said that big data is the information asset characterized by such a high volume, velocity, and variety to require specific technology and analytical methods for its transformation into value. So there are 4 V's in big data: volume, velocity, variety, and value. Echocardiography checks all the boxes. The volume of data is tremendous, and it is presented to us so quickly. The information comes in a number of different varieties. And all this conspires to keep the value of the echocardiogram from being fully realized unless and until we apply some specific technologies and analytical methods. But echocardiography does not exist in a vacuum. As I mentioned earlier, it's only part of the big data that we can use to better evaluate and care for our patients. Could this become part of a new cardiology care paradigm? Which brings us to the challenge of using big data for clinical prediction, where we incorporate the echo findings with other key pieces of clinical data. Can we correlate echo data with patient outcomes in large data sets and derive a clinical prediction tool from the echo and other data stored in a person's medical record? By definition, we have the 4 V's of big clinical data: volume, velocity, variety, and value. So machine learning is appropriate to transform the echo into an element in a powerful prognostic tool. Let's examine whether it's realistic to use echo this way. Diller and Associates describe estimating prognosis and guiding therapy in patients with congenital heart disease. This main figure from their work illustrates how information housed in the medical record covering diagnosis, medications, and symptoms can enter a deep learning network to produce a disease severity score. This score can then be processed with demographics, lab, ECG, and exercise parameters in a Cox multivariable survival model to produce predicted survival as a function of time. In this framework, echo and imaging fits right here with other clinical inputs. Next, let's review an example of how that might work. In this very exciting work published in Nature, David Wang et al. Trained a neural network for beat-to-beat assessment of cardiac function using video analysis in conjunction with a neural network that operates in time. This network had several amazing technical innovations, including weak supervision and unique convolutions. And on the right, you see the results. One important feature of this network is that the output can be transformed to match what is acquired in a normal clinical echocardiogram. In another study employing unsupervised machine learning in heart failure with preserved ejection fraction, these investigators found that if you include echocardiographic features, biomarkers, and electrocardiogram data, 3 groups of heart failure and preserved ejection fraction emerge. And we see clearly that each of these 3 phenogroups have very different survival curves, further demonstrating the predictive power of this kind of approach. But can we go even further and connect continuously acquired information, continuously acquired data from wearable devices and technology into this big data-driven new cardiology? Well, the new cardiology powered by machine learning will help protect our patients. Dangers lurk everywhere for our patients. We don't want them to hit the metaphorical bridge overpass. So if our technology could provide us with better advance warning, that would be a real advantage for us and for our patients. Of course, a surveillance and warning system in healthcare will be more sophisticated than a sign over the road. So let's consider what the specific elements of such a system would be. We need three things to develop such a warning system for our patients. First, reliable physiologic sensors that continuously gather meaningful data for input into our system. Next, we need an artificial intelligence algorithm to convert the input to output in the form of sensitive and specific predictions about the patient's health. Finally, the system must be well connected in a couple of ways. First, the input would connect data from many sources for processing by our algorithm. And second, rapid and reliable communication is needed to connect the output with the people who need to take action, the patient and the physician. A word about physiologic sensors. As early as the 1960s, the creators of Star Trek imagined the tricorder, which could detect all sorts of physiologic signals, but it was neither wearable nor real. Many decades passed, and now we have photoplethysmography, electrocardiography, accelerometry, and more on our wrist. Photoplethysmography, or PPG, provides oximetry and a pulse signal. ECG measures the electrical activity of the heart, and accelerometry can monitor activity by counting steps. And all the three are low cost and non-invasive. Next, we need to have signal interpretation sensitive enough to detect trouble and specific enough not to flood us with false alarms. Machine learning algorithms are proving suitable for this task. The algorithm in this schematic has a learning process that is depicted in the gray shading here and converts the output in red, converts the input in red to the output in blue in the form of sensitive and specific predictions about the patient's health. For example, diagnosing atrial fibrillation, AFib, from the ECG here. Now that we have introduced a basic summary of wearables, the massive amounts of data they generate, and the tools, i.e. machine learning, to analyze this data, we'll now go over the key trials that have revolutionized healthcare involving wearables. One of the first trials to introduce wearables was the Apple Heart study conducted by Apple and Stanford Medicine. At the time, it was the largest ever clinical trial and sought to determine if the Apple Watch could detect an abnormal heart rhythm, atrial fibrillation, AFib. There were over 400,000 subjects. Over 2,000 were alerted to have an irregular heart rhythm. However, almost 80% of these were excluded, most for subjects failing to follow through with evaluation to identify their rhythm. Nevertheless, it was demonstrated that the Apple Watch, with its algorithm, detected AFib with a high degree of accuracy, suggesting it may be a screening tool for identifying people at risk and may help improve the management of AFib. Later, Lubitz and Associates published the results of the Fitbit heart study, which confirmed excellent positive predictive value for AFib detection during using the wearable device, the Fitbit. And in recent years, the applications of wearables in cardiology and other areas of healthcare have really exploded. Another example is how we can distinguish obstructive sleep apnea severity levels using wearables. A and Associates investigated a method to do that as established by a formal sleep study. So they enrolled 3,000 patients and used a wearable photoplethysmography for input to train their algorithm, which is called the gradient boost, and we'll talk about it in the next slide. The input features included age, gender, BMI, the mean and the fastest nighttime heart rate. And the model performance, as assessed by area under the receiver operating characteristic curve, was excellent for detecting obstructive sleep apnea of all severities. Because a formal sleep study is a scarce resource, this type of algorithm is valuable to prioritize which patients need to undergo a sleep study. The algorithm they used for training was the gradient boost, which is a form of supervised learning well suited for classification tasks. It relies on decision trees to link input features to outputs. The individual decision trees are weak predictors. However, combining numerous trees in an ensemble can produce a very strong predictor. In gradient boost, this combining takes place in a stepwise fashion, modifying the algorithm at each step, or in the jargon of machine learning, the gradient is enhanced and the loss of function is minimized. And as a result, the predictive accuracy is boosted, producing an algorithm sensitive and specific for clinical use. Another example of training a gradient boost algorithm is this report of a machine learning model to detect COVID infection in healthcare workers. They enrolled 407 healthcare workers and 49 tested positive for COVID. The subjects wore an Apple Watch for continuous photoplethysmography. Heart rate variability was entered as input feature along with age, gender, and body mass index. The resulting algorithm had high sensitivity for predicting COVID infection. The innovation here is that physiologic metrics from a wearable device can predict an infectious disease with remarkable accuracy. All of us know ultrasound is a crucial diagnostic tool in medicine. This year, Hugh et al. Reported in Nature a wearable ultrasound, a wearable echocardiogram for continuous real-time cardiovascular assessment. This device gives dynamic echocardiographic images even with the subject doing intense exercise. The image processing and deep learning models from this wearable ultrasound gives continuous output of cardiac performance, including ejection fraction and stroke volume. Further development of this technology would make it highly desirable for cardiovascular disease management. And I think this has unprecedented capabilities in clinical practice in adults and children and have potential benefits in the athletic populations as well. As powerful as our deep learning algorithms have become, we are not going to see their full potential if the pieces of clinical data are kept in silos, isolated from other pieces of clinical data in other silos, so we can use only one piece at a time. To be connected in this sense means to knock down all the silos that contain and separate each kind of clinical data, imaging, lab, history, demographics, comorbidities, and others, including input from variables, and train a machine to learn from all of it together, not just from what happens to be contained in an individual silo. So the full potential for the electronic medical record to do this has not yet been realized, but major work is being done. An example of connecting medical data of diverse sources is this study predicting survival after echocardiography. Using data from a very large number of patients from a tertiary care health system in the US, they input numerous cardiovascular codes, demographics, physical findings, lab values, and echocardiographic parameters. The best algorithm was a nonlinear random forest. This is another ensemble algorithm built from decision trees. But unlike the gradient boost I mentioned earlier, the random forest builds each tree independently and then combines them on a majority rules basis. The performance of these models exceeded all commonly used clinical predictions, risk prediction scores for predicting survival. Our systems need to be connected in a different sense as well, because even the best algorithms don't help much unless we can get the output rapidly and reliably to the right people, who are the physician and the patient. The messaging modules of modern electronic medical record systems have a big role to play, connecting the output of algorithms with the physician and the patient. We speculate that younger generations of patients are likely more comfortable with digital communications and might embrace them with enthusiasm. But is this really an effective way to engage patients from the output from wearable devices? Will they respond appropriately? This question was addressed in the electronic Framingham study when participants sent in their heart rate and blood pressure data. 3 types of electronic notification strategies via smartphone were tested. Adherence was superior when the notifications were personalized, including the participant's name, and tailored to previously transmitted data. So personalized messaging to patients promoted patient engagement and adherence more effectively than standard notifications. While all these technologies may help clinical care by serving as decision aids, they also give us physicians a unique window into our patients' daily lives, unavailable to us if we rely only on a series of clinical snapshots at the time of their office visits. The tiny fraction of time patients are in the outpatient clinic is poorly representative of what goes on as they live their true lives. Wearable tech could potentially enable us to fill the gaps between visits, which is key for patient-centered care, especially in the management of chronic disease. Digitizing data in this way that wearable tech allows can make patient experiences analyzable and usable in the clinical context. So armed with this between-visit data, we have the opportunity to improve clinical outcomes and quality of life by early intervention. In the process, we have recruited the patient to be part of the medical care team, the physician-patient team, which may pay dividends through patient engagement and treatment compliance. Perhaps big data will fundamentally transform the way we evaluate and manage patients. But before we discuss how realistic this would be, another question is also relevant. Will the power of big data also revolutionize the way we perform and interpret clinical research? Will the randomized control trial continue to be the gold standard from which generalized practice guidelines are developed? Or will we discover a better, more personalized way to apply the data from these trials for patient care? I want to be clear, randomized control trials and the practice guidelines based on them are great. We would provide much poorer care without them. But there are problems. Here is an unreal method section you will never see. We recruited from our hospital 500 genetically, socioeconomically, physically, and demographically identical patients with disease X of precisely the same severity who manifested it precisely the same way. End quote. Said no clinical researcher ever. Such a study population is unavailable, and even if it were, you could not generalize the conclusions to the real world, which looks more like our next slide. The minor variations among the teddy bears recruited into most RCTs leads to a concept called heterogeneous treatment effect. Because the bears are different, some might respond well to treatment A, the blue arrows, but others, shown by red arrows, might respond better to treatment B. So if you do a randomized controlled trial in the hopes of developing a practice guideline, you would conclude that treatment A is superior, and you would publish recommendations to use treatment A as it works better for most bears. Our research question then is, if we develop a predictive model to distinguish red arrow bears from the blue arrow bears and allocate treatment accordingly, would our bears do better overall than we just apply the best treatment from the RCT for everyone? We approached this research question by taking 3 published pediatric randomized controlled trials with robust data describing heterogeneity of the study population. One was the NIH Kawasaki disease trial, in which the adverse outcome of coronary artery abnormality was encountered less often among those receiving IV methylprednisolone. The second was an NIH trial of modified Blalock-Taussig Thomas shunt versus right ventricle to pulmonary artery shunt in single ventricle reconstruction, which demonstrated fewer adverse events in the latter group. The third was the therapeutic hypothermia after pediatric cardiac arrest trial, in which adverse outcome differences were not observed, and the trial was closed inconclusively. Jacomin, Van Endinde, and Manu in our team led this work, and they simulated the outcomes that would be achieved if care were individualized, such that trial patients were allocated to the care predicted to be best for them, and compared those outcomes to the universal application of the superior care option from the RCT. Predictive allocation, illustrated in the far right bar in each graph, resulted in fewer adverse events than either option tested in the trial, even when that option was identified by the trial as superior. This work is currently under review for publication, but already we know the next step: move beyond simulations to real-life trials of predictive allocation. This approach may prove especially relevant to pediatrics, where performance and interpretation of randomized controlled trials is hampered by the special challenges of relatively rare conditions with particularly diverse clinical manifestations. As we approach the conclusion of this talk, you probably noted that the dream of the new connected cardiology has not yet been fully realized. It feels a little like trying to assemble Stonehenge using instructions from IKEA. Sometimes you wonder if it's going to look like the diagram when it's done, or on a more basic level, are we ever going to get this built? Assembling data that includes physiologic signals, integrating it using machine learning with other diverse data like genetics, imaging, labs, demographics, and diagnosis to provide personalized precision medical care with clear and rapid communication, promoting patient engagement, satisfaction, and trust is a big job. There are realistic concerns, so it's appropriate now to consider the challenges facing AI implementation. AI in healthcare presents specific challenges. Gerke et al. Identifies the following ethical and legal challenges. Starting with ethics, we must ask, how do we maintain adequate standards of informed consent for patients whose care is driven in part by AI? How do we assure that AI does not lead to worse outcomes? Are these algorithms fair to all, or do they introduce biases against vulnerable minorities? Does collection of large volumes of clinical data open the door for the loss of privacy? Legal issues follow. What laws should be in place to assure the safety of AI? Do algorithms need to go through a stringent approval process, like a new drug? Who is held liable for any harm resulting from the use of AI? What laws need to be there to protect privacy? What cybersecurity safeguards need to be in place to prevent hackers from accessing sensitive information? And finally, intellectual property. Who owns these algorithms and who can rent or sell them to healthcare providers? As we work out these important questions, there is a great deal to know about machine intelligence in pediatric cardiology. We have reviewed the definitions of artificial intelligence, machine learning, and algorithms. We have seen how these methods can be used to process medical data in novel ways to produce accurate, clinically relevant predictions, which might be used for personalized precision care. We discussed big data and have come to understand the importance of integrating its diverse sources, including images, wearables, and the electronic medical record, and how we must break down the silos in which these data are often stored separately from one another. We touched on the potential impact on how randomized clinical trials might be performed and interpreted in the future, applying predictive allocation of treatment strategies. And finally, we emphasize that there are real challenges to all of this. We need to assemble all the pieces while being fiercely protective of the patients we served and meticulous with our methods to assure quality results. And if we can successfully assemble all the parts of our new approach to medical data analysis, then the result could be beautiful. I want to acknowledge my data science and analytics team at Hopkins, and thank you for your attention.